This conference will now be recorded.
Assalamu alaikum everyone. Hello again. This is Fiza Gilani, and sitting with me is Dr. Syed Ifkhar Hussain and Maya Hussain, our technical support. So today is our webinar number 6, and the topic is Fostering Health, Hope, the role of mental health care in HIV care. Our guest speaker is Jamie Kenny, PhD, and we will introduce her in a few minutes. And we welcome everyone, and we want to thanks everyone for doing this great work on the grounds in Sindh, Pakistan. First of all, our disclaimer. Please remember, all views expressed in these webinars are of individual presenters only and do not represent views of any institution. Please remember, this is a volunteer project aimed to reduce stigma and increase awareness about HIV disease in Pakistan. No one is hired and paid by any institution to do so. Our group does not affiliate itself with any political, ethnic, or religious denomination. During the presentation, please keep all your audio speakers muted. Only mine and my guest speakers, Dr. Kenny and Dr. Somru's computer will not be muted. Please write your questions in the right-hand side panel. Please ask questions relevant to today's topic only and keep them brief. We will send you the evaluation form in a day or so about all these webinars to help us evaluate the impact of our efforts. So today, after this introduction, our guest speaker, Jamie Kenny, will start, and her topic is Fostering Hope, the role of mental health care in HIV. After her presentation, both Dr. Kenny and Dr. Somru will be taking questions about the role of counseling and medications in HIV care. Our HIV communication project's overall goals for this webinar series were to reduce stigma and increase awareness about HIV disease by empowering healthcare providers with HIV disease knowledge and ways to improve provider-patient families communications in Pakistan. Review of previous webinars. This is our 6th webinar. So in webinar 1, different aspects of HIV disease, including definitions, disease progression, stages, symptoms, and transmission modes in general and specific to Pakistan were discussed. We also discussed myths and facts related to HIV disease in general and specific to Pakistan. In webinar 2, our guest speaker, Dr. Phil Chan, discussed the standards of HIV testing in general and in resource limited settings, required lab testing for disease management, and standard precautions related to HIV lab procedures. In webinar 3, our guest speaker, Dr. Joseph Garland, discussed HIV care cascade, including HIV diagnosis, treatment, and retention, and presented Mariam Immunology Center clinic settings and routines. In webinar 4, our guest speakers, Dr. Susan Kuyuban, Dr. Jerome Larkin, and Dr. Sabina Holland, talked about preventing mother-to-child HIV
वीडियो तो
transmission
कितना रिव्यू ऑफ प्री वेबिनार है बस मैं तो कुछ नहीं असल में
and
ऑडियो
taking care of infected infants and children.
जी सर हाँ फिर स्लाइड चला दीजिए बिल्कुल सर
In webinar 5, our guest speakers, Dr. Natasha Ryback and Dr. Martha Sanchez, talked about different treatment options for HIV-TB, HIV hepatitis B, and C co-infections. Last half an hour in every webinar is dedicated to discussions on importance of open communications between healthcare providers and patients about the HIV disease. So our objectives today are learn how to help patients before HIV testing, learn how to help patients after positive HIV test results, understand the importance of open communications between healthcare providers and patients about the diseases. So our guest speaker, Dr. Jamie Kenny, she has a PhD and is a licensed clinical psychologist working in corrections setting for the past 7 years. She has worked with inmates and detainees of diverse demographics and clinical histories. Her extensive work in the community as well as detention center and prison settings has contributed to her experience in crisis intervention and stabilization, step-down treatment approaches, and long-term ongoing maintenance therapies. Dr. Kenny has experience working with neurodevelopmental disorders, geriatric and pediatric populations. Currently, Dr. Kenny oversees mental health programs and provides psychological care for thousands of patients in California, Arizona, New Mexico, and Oklahoma. She has a particular interest in education and program development. Before beginning her work in correctional psychology, Dr. Kenny worked as an integrated primary care and outpatient psychologist with a focus on mitigating risk through identification of mental disorders and through providing mental health treatment for individuals with chronic medical illnesses. So I present to you Dr. Jamie Kenny. So please just bear with me. We are making her presenter because she is presenting her presentation from Arizona.
Okay, Jamie.
Good morning, everyone. It's a pleasure to be here today, and I'm grateful that I have the opportunity to talk with each of you about the role of mental health and how that can improve outcomes in patients with HIV. To get started, this is what I would like to see our time today look like. To begin with, I'm going to talk about mental wellness or unwellness and how that is different from mental illness. I'd like to talk about the role of stress. And then after we come to a consensus on what that looks like, I'm going to start with what an ideal practice would look like. One that none of us can attain, but what we would try to attain in our practices. And then I'm going to bring this back down to where we're at today, what you have available as your resources, and what we need to do to get started. And then finishing up the session, I would like to talk about a few things that we can consider doing now, but with longer term goals in mind. And have a session for question and answer. It might be longer than 30 minutes. The beauty of mental health is it's a little bit of a gray area and it can be customized based on the need. And so I want to give you guys plenty of time to talk about the issues that are specific to what you're experiencing in Pakistan and how we can help. So let's talk about what it means to be mentally well versus what it means to have a mental illness. To begin with, people can be mentally well or unwell, and it can have absolutely nothing to do with whether or not they have a diagnosable mental disorder. And in fact, you can have someone with a diagnosable mental disorder and they can have good mental wellness. They're taking their medication, they take care of themselves, they eat well, they're engaged with their family, and for the most part, they're functioning well, but they have a diagnosable disorder. We also see many people who have poor mental health, but they don't have a diagnosable disorder. And the reason I think this is important to differentiate is because mental wellness or mental health in general is where we're going to see an impact on how HIV treatment is going to go. And so this affects every patient. And so we want to make sure we're looking at the wellness and the behaviors of all patients, whether or not they are mentally ill. And of course, if someone is mentally ill, we want to refer them out appropriately or treat them in-house with the medications they need for that disorder. But we're looking at more than whether they're diagnosable or not. We're looking at every patient that comes through the clinic and how they're handling their disease process from a mental standpoint. So the focus of the physician is to foster good mental health and in all patients. The reason we want to do this is people with HIV have a higher rate of mental illness than the general population, so we want to screen all of our patients. Secondly, they're twice as likely to have depression than the general population would, and they have increased levels of anxiety and other disorders as well. People with HIV have a higher risk of mental health symptoms related specifically to the disease process than the general population would by other infections. Antiretroviral medications can cause symptoms of depression, anxiety, it can cause sleep problems. So the medications alone can cause mental health symptoms in people who are otherwise mentally well. And the stressor of the process and the treatment can also expose a latent mental disorder and cause it to be activated. So we want to watch for those things. Another thing we want to watch for is what I call chronic sorrow. And you can think of chronic sorrow as a grief process not much different than when you lose someone to death, except it doesn't stop, and that's why they call it chronic. When you lose someone you love and you go through a grief process, you have a termination of that process at some point and an acceptance, and you move on. Someone who's struggling with a lifelong disorder experiences chronic sorrow anytime a milestone isn't achieved, anytime there's a setback. And so patients who have a chronic disease process, including HIV, can struggle with chronic sorrow. And that when they experience that grief again, it can reduce treatment compliance. They're maybe not going to take care of themselves. They may feel hopeless again. And I put it increases the likelihood of risky behavior, but I want to be careful that to state what I'm describing is self-neglect here. We're not talking risky behavior and erratic behavior that you would see with a mania or some other mental impulsivity. We're looking at risky behavior, meaning they're not compliant with their treatment and they're not taking good care of themselves. Another thing that patients with a chronic disease deal with is stress. And stress is also chronic. So we've got chronic sorrow and that sense of grief and loss that may come up with these patients. There's also chronic stress. I typed loss of family and community support. I understand that some communities are very supportive of patients and very supportive of their family members. And yet within that supportive system, even if it's a multi-generational system where you have many people that can help someone who's physically unwell, there also comes with it sometimes a set of family mores or stigma or punitive behaviors or maybe family exclusion, guilt, maybe some nagging, things like that that we don't think of as big deals. But the thing about stress is it's additive in nature. And so if you were to take a glass jar and fill it full of big candies and little candies, eventually the jar would be full and it would overflow and we would have too much candy. In this case, we can look at stress, big stressors and little stressors. You fill it full and it doesn't matter if it's big or little, it eventually overflows and we've got a mess to clean up. The little things can add up. Likewise, when we remove stress, because it's additive in nature, we can make a big difference by removing minor stressors. So for a patient with HIV, where HIV I would consider to be a big stressor, we might not be able to get rid of HIV. We can't cure it. We can maintain it and we can provide them ways to have a healthy life. But if we can reduce those little stressors, we're going to help improve the likelihood of success. Things that can cause stress: lack of access to medical or mental health care, if they're in a rural community or if they have difficulty with transportation to their appointments. Access to medication and management of medication. Do they understand how to take their meds? Can they get them? Can they afford them? When they're at work, is there a chance that they're going to lose out on opportunities to promote? Are there certain tasks that are causing fatigue that might be affecting their treatment? Stigma, anywhere, stigma is an issue. Even in the United States, we see stigma as an issue with HIV. Discrimination, abandonment, punishment, estrangement, that goes along with stigma, and that can occur in any setting. The other thing that can contribute to stress for them is changes in their physical appearance once the disease process develops into AIDS and they start declining. So they're experiencing a number of stressors that we can focus on, and we can find ways to take out those little stressors and improve the likelihood of them being able to manage the big ones. So now that we've talked a bit about mental wellness, mental health, let's talk about what an ideal practice would look like, one that we're all aspiring to and none has achieved. But I'm going to pull from the models used in the US as an example of what is going well. And in the United States, what we're finding is a multidisciplinary approach to complicated patients, such as HIV, is effective. And so what you're looking at is the need to have medical specialists, case managers, social workers, nurses, a psychiatrist available, psychologists available, and counselors. And then religious leadership is often helpful too. In the US, we call it chaplaincy, And so many hospitals and other treatment facilities will have the availability to provide religious support, which helps improve treatment compliance and outcomes. Within the multidisciplinary approach, we have a subset of agencies that are doing something called an integrated care model. Rather than taking the multidisciplinary approach and having patients go from one facility to another clinic and then to this office over here, we then will integrate it into one location, and the patient gets all of their needs, or as many as possible, met in one location. We also provide multiple services for these patients during a single appointment. And what I refer to as allied health services are provided free of charge. And that has to do with the way billing occurs and the rules around billing in the United States for medical care. But what it means is when we agree to do this in an integrated format, the medical appointments are paid for, and everyone else can just come in and do what they need to do, provide the screenings, provide the resources, and fees are no longer an issue because the patient has paid for that one appointment. And if there's something that can't be accommodated in that one location, we make immediate referrals. So if a specialist is needed, you can have a case manager on the phone right away making the follow-up appointment before the patient ever leaves. And if other ongoing follow-up appointments are needed, even within the clinic, that can be taken care of in that one-stop shop. So looking at that as the ideal, we need to talk about where to start. And you're doing some of this already, and I'm going to just talk basics about what we would expect to see as far as mental health screening and treatment goes during the start of the HIV treatment, starting with the testing, actually, pre-testing, and then moving on. And then we're going to talk about some things you can add to that in a little bit. So pre-testing intervention, I'm telling you what you don't already know. You know this already. Before you test a patient for HIV, you're going to review automatically the limits of confidentiality. So they're going to know who's going to have information about their test. You're going to make sure that they want the test and they agree to have it. So you're going to get a consent. You're going to identify to them the risks and the benefits of getting the test. We're not even talking about the treatment down the road. We're just talking about getting the test and knowing the results. And then we're going to tell them how we'll use the information. Is that just for the clinic's sake? Will it be used for research? How are you going to store this information? And then you're going to talk about the false negatives, the false positives, the risks of what the limitations of this testing can do for them. So you already know that, but where mental health can come into play is making sure that when you're providing this information, it must be provided in a way that the patient will understand. And it must be culturally sensitive and address any objections or fears that that person is going to have when you understand their social practices and their beliefs. And so we don't make a blanket judgment that everybody believes the same thing and thinks the same way about something. Some patients are more sensitive about the possibility of having HIV than others are, and that's going to affect their compliance with treatment or willingness to be tested even. Even in the pre-testing phase, before they submit to the test, it's important, if you have it available to you, to provide information about advocacy groups, support groups, anything local, national, or even international that could help that patient and prepare them for the information they're going to receive and the treatment that they will have. And finally, and probably the biggest point on this slide, is that it must be provided in the language that they'll understand. I, for one, struggle with using big words, and I'm reminded from time to time that I'm talking in too big of words. So we need to talk to the patient on a level that they understand and make the information meaningful to them. So avoiding jargon, avoiding medical terms, and explaining it in a way that they know exactly what they're consenting to do. Once they've agreed to the test, the situation gets a little more complicated, because just because they did the test, they might not want to know what the test results are, and we need to be sensitive to that. So when the patient returns and you're going to provide them the results of this test, you need to review the purpose of the testing once again and remind them why they got it. And on the next slide, I'm going to talk about what we call the SPIKES protocol, which is an intervention you can use to determine their mental readiness to hear the news. You're going to, at that point, provide a treatment plan if necessary, and then also follow-up emotional support, which we can talk about in a minute as well. So on the next slide, we're talking about the SPIKES protocol. And so at this post-testing session where you're going to present to the patient the results of their test, you need to make sure you're in a setting where they feel safe and comfortable, recognizing whether they need privacy or they want family there to hear the news, making sure there's no distractions, making sure that others cannot hear the news that shouldn't be allowed to, so not talking in a common area or a public setting. And then we need to assess the perception of the patient. And that's going to happen through a conversation that the provider will have with the patient about what they understand they have done by taking this test and how they're feeling about getting the results. And you can just ask them that. So do you remember why you came in? And we did this test. Tell me about the test. And ask them to teach it back to you and explain what happened. And we've got your results. Are you ready to hear them? And have a conversation about why or why not they're ready to hear it. And that goes into the invitation. And if they're ready to hear the news, then you're going to share your knowledge and provide an empathic response, and then come up with a plan. If they're not ready to hear the news when you invite them to talk, that's where perhaps, whoops, I skipped too many slides, excuse me. That's where providing a sort of an intervention or emotional support, bullet number 4, and that can be delegated. Perhaps this patient is not ready at the moment, but the doctor has other patients waiting to see. So having someone available that this can be delegated to, that can talk further with the patient, might lead to the patient deciding to go ahead and hear the news and come up with a treatment plan that day. It just might mean that they have to go to a separate room, have a side conversation with someone, come back, and then the provider can provide the results. At each appointment thereafter, it's important that mental health screening be considered vital, and that every time the patient is in the clinic, we're assessing for the emergence of mental health symptoms. Because again, even if they don't have a diagnosable disorder, we're wanting to make sure they're well and that they're compliant with their treatment. Also, at each ongoing appointment, we're going to monitor for medically caused symptoms and treat. The first thing we do in mental health is rule out any medical cause for the symptoms that we believe are mental health. The reason we do that is because, as you know, there are certain medical conditions that can be fatal even, that will present like a mental condition. Or yes, a mental condition. So for instance, delirium is typically a medically caused condition, and that can be from encephalopathy, and liver failure. Maybe they're disoriented from kidney failure or heart disease. Hypothyroidism is going to look like depression, but if we treat the depression and we don't treat the hypothyroidism, they're not going to get better. So we monitor for medically caused symptoms, treat the medical symptoms first, and then what is left we can treat mentally. We monitor and provide brief on-the-spot interventions and refer to support staff if possible for ongoing follow-up of if they're showing some mental illness or mental unwellness. And if they're showing signs of mental illness, we will, of course, refer to psychiatry. And so that's the point where we would, either the medical provider or the medical provider in consultation with the psychiatrist, one is not available, will prescribe. And we can talk about some tools. I did not put it in the slideshow, but there are some tools you can use that will help you determine if a patient's symptoms are simply mental unwellness or if it's time to make that referral and consider meds. So my presentation is start to finish, but we're never finished. And so I want us to look at patient care with HIV and with mental wellness to be something from birth to death, and particularly someone with an HIV diagnosis from the time of diagnosis until death. And so we're never going to stop having patients to treat, and we're never going to stop having mental wellness to look at and evaluate. But what can we do to expand upon simply providing on-the-spot interventions for pre-test, post-test, and ongoing appointments? I'd like to think that there are other things we can do. To begin with, in all of our sessions, we need to focus on healthy behaviors. Prayer and meditation is one of the best things we can do for any of our patients, is foster those principles. They are known not only to increase hopefulness and a sense of purpose, but also can reduce anxiety and improve sleep. Mindfulness exercises are helpful as well. Exercise is given that helps all of us. Fostering healthy family relationships will help with treatment compliance. Normalizing behaviors and feelings. I think it's important that we, again, know there's no right or wrong way to feel about their experience of having HIV. And so we normalize that to them so they don't feel so different or unusual. And then set realistic expectations and encourage hopefulness and sense of purpose. When a person has hope and a person has a sense of purpose, they can overcome a lot of challenges. And when I say set realistic expectations, that goes both ways. We want our patient to understand if there are limitations, but we don't want them to put limitations on themselves that don't need to be there. So we can set the bar high because they can live a relatively normal life. And so we want to instill that hope and allow them to develop a sense of purpose for their life in spite of an HIV diagnosis. Some long-term solutions that I thought would be helpful in raising the bar from what we're doing right now to that aspirational goal of an integrated program would be perhaps the use of telemed or telemental health services where the technology is available. And that can be in clinics or in the medical schools. It could be maybe in the mobile clinics that are running. If there's access to satellite and the ability to, or Wi-Fi, to have some internet connection, we can reach patients in the community and provide that feed back to a centralized location and have counselors available or psychologists, and definitely psychiatry. That would be a great use for psychiatry. So if we don't have the psychiatrist to go to them, we can maybe bring them to the psychiatrist through the use of telemed. Down at the bottom bullet, utilizing resources through U.S. partners. I think I want to mention that before we do the other bullet points. Maybe even utilizing, if you don't have enough qualified staff, psychologists, counselors, social workers, utilizing resources in the U.S. through your partners, so through APNA, for instance. Going back up to bullet number 2, peer facilitators and advocates. This is something that any community can do if you have a medical provider who is willing to create a program that is supervised closely. You don't want peers of your patients providing care and having information and using it irresponsibly. So if you have someone who's willing to supervise closely on your team, though, you can get free to low cost assistance. And what these peer facilitators and advocates do is they can be patients who have HIV diagnosis as well, or they can be patients who are just interested in this field, or volunteers from the community that are interested in working with this population. And you train them. They cannot provide therapy, they cannot diagnose, and they cannot screen for mental conditions, but they can be the ones who listen when the patient simply needs someone to talk to. They can provide handouts on sleep hygiene, handouts that the doctor has approved on anxiety reduction strategies, on depression, on medication compliance. They can be the ones to maybe do home visits and make sure that the home environment is healthy and supportive. And again, they're volunteers typically, or they work at a low cost. So developing a peer facilitator program does not cost much. It simply costs for the person providing the training and the oversight. I think it's important to consider delegating any non-medical or non-psychiatric function to support staff at some point in the growth of your programs. There's no need for the expert to provide non-expert material. Your mental and your medical experts need to spend their time working with all the patients that need their expertise. And in most settings, there are many eager staff members who are willing to support the doctor in those functions. And so who is your go-to nurse that understands mental health? Who is your nurse or mental health provider, if you have one, that you can rely on, that you can have as your point person to make the mental health portion of the program run? That person is accountable to the medical doctor and communicates closely, but takes that burden off of the medical doctor and can develop a program with case management, making the calls for the patient, making sure the nursing staff got the meds to the patient, making sure those home visits are going well. Anything you can delegate to somebody allows you to have more freedom to do the work you're trained for. And my final thought was, I called it professional tourism, not to be confused with tourists who go and seek professional help overseas. This would be utilizing professional organizations and individuals who have a desire to help in a philanthropic way or an altruistic way. Collaborate with those organizations and bring in groups that can work with your patient population for a period of time. Maybe they can help set up programs. Maybe they can help do these clinics in certain areas where you need to get a lot of people seen in a short amount of time. That would be another option. Excuse me, please. Okay. So the goal that I have, and I hope that you have as well, excuse me, is to instill hope. And if there's one thing you got out of this presentation today, it would be to do that. Excuse me, I'm sorry. That would be, if you can instill hope in your patients, they're going to improve their treatment compliance, and it's going to improve their quality of life. So at this point, I think I'd like just to open the floor and answer any questions that you have.
Thank you very much, Dr. Kenny. It was very good.
Thank you.
So, Dr. Sumro, you want to add your opinion or you want to start the question answer session?
I think I will just start the question answer session, and Jamie and I can answer and help anyone from the centers who are attending the seminar.
Very good. Thank you.
I will go ahead and give a chance to the Benazir Bhutto Medical University, Dr. Jamro, if they have any questions, and Dr. Farooq.
I am Dr. Farooq Sumro from the Benazir University, Ladkana, and with me the former Vice Chancellor, Dr. Ghulam Rao Pathan, Professor, is sitting with me. So my question is that here is the problem is when the patients are diagnosed with HIV, first test, they say that you have the HIV, but no that other tests they have done. So patients behavior become changed, and even after during treatment, we need the counseling, we need the behavior change. BCC is very important in Ladkana. I went today Ratodero. So patients, HIV positive children, parents, and they are crying. We have HIV, we have HIV, but nobody there is for counseling, pre-test, post-test, and the BCC performance. Problem of the patient become the psychiatry. There the behavior very aggressive. Today I seen. I went there the lecture on the HIV there. So what is our people's the only very important is the BCC and the children's treatment. So I request, thank you very much, your kindness to aware to building the capacity for us. So again I will thank you, but please again I need a big stigma in Ladkana, so I need a more this type of the psycho changes lectures. Thank you very much.
Jamie, do you want to comment on his Dr. Sumro's statement?
So his statement, can you restate that for me, please?
Dr. Sumro is expressing his frustration of healthcare professionals and the patient and their families about resources for providing them pre-test, post-test counseling and referring them to the appropriate mental health counseling. So patients and families they are very frustrated, and they don't know much about HIV or AIDS, and they do not understand the treatment process, and they also do not have the enough referral system where they can get help. So they had an awareness session today where there's an outbreak in Ratodero. In the anger and frustration, these mental health professionals they encountered today, he's talking about his own frustration and frustration of the patient and their families.
Yes, absolutely. It sounds like it's happening on a large scale I think that some community awareness is probably really important, and if there's a way to do a campaign and providing awareness, that will be helpful. Secondly, the use of a group for these patients, a group that could do an educational seminar for the community would be helpful. And that would be done for, just open it up to anybody and provide general understanding about HIV and the treatment process, what that looks like. And that could be for anybody. And so some community forums would be helpful. That will reduce the stigma. It might help reduce some of the anger. And I think it also points to the importance of having some accessory team members available that can do some of this work for the physicians. One thing comes to my mind now as a little bit of a digression is if the providers burn out and they're not mentally well because they're overwhelmed, how can we expect our patients to be well? It's important that we support our doctors, and it's important that we delegate some of the work from them and bring other people in that can help. So I think this would be a perfect opportunity to get a nurse or some other educator that could provide a seminar for the community, or just for your patients if you want it, but do it in a group setting, and then you meet the needs of many people at once.
Dr. Sumru, can I please add one of my comment here?
Sure.
In one
Please.
of the
Professor.
webinars, we requested medical colleges to activate their student groups and assign different small projects to different students to go in community or create some kind of community awareness programs. I think using the students and giving them some credits is very useful, and we have a large student body there. So I think this is one existing source which you all can think of. Thank you.
Thank you, Dr. Fiza.
Dr. Professor Murtaza Pathan, Professor of Pathology, and formerly hold the charge of Vice Chancellor of Shaheed Muhtarama Benazir Bhutto. I am thankful for this valuable presentation, which will be
वो
helpful.
तव्हां खे जेको तो कन सर असल में न हाणे हो प्रिविलेज सर हुननि तरफ़ां सां कोई प्रिविलेज
Go ahead, Dr. Murtaza.
This valuable submission in the presentation will be helpful in our this problem in the area, and I hope there will be much more helpful in the building capacity when this program will be run. I am also thankful for the arrangement and help from our colleague and son of soil of this area, our Dr. Aziz Sumro, for arranging of this valuable and the nice information and the program arrangement from the United States. Thank you very much.
You're very welcome.
You are welcome, Dr. Pathan. I see Dr. Hamidi. Dr. Hamidi, do you have any questions?
Thank you very much, Dr. Sumro. No, in fact, I think Dr. Kenny has summarized it very well. Just to add on the comment, and Professor Jamro was requesting more services and awareness in his area, is that we can actually arrange some kind of webinars to the general public, and preferably in either Urdu or Sindhi, which they understand more better, and educate the general public about AIDS, HIV, other medical illnesses associated with that, as well as an impact of such illnesses onto their mental status and how to identify, request help for that, and deal with it. So I think that would be something to look forward in future. Dr. Sumer, I know you have been pretty active in arranging all those seminars, and I think that will be a good resource if we can use it. Thank you very much.
Thank you for your comments, and sure, we as a group and we as a with our available resources will be talking about and speaking to local university ways and means we can help them. Dr. Khatri, I see you online. Do you have any question, Dr. Khatri? Dr. Khatri. Okay, I will go ahead and give a chance to Dr. Rabia Awan. I see her online. Does she have any questions?
I don't have a question, but I really appreciate the effort Dr. Rizwan Naeem put in and all of you. And I really appreciate that you are educating people, the best thing in the world you can do. When you educate people, in turn, they educate others, and a lot of people are going to benefit from it. I'm a family physician. I believe in preventive medicine more than actual disease. But if somebody has lethal disease like HIV, a lot of things to go around, and I agree with all the speakers. And thank you so much, all of you.
You're welcome. Dr. Mashadi, do you have any question? Dr. Rida Mashadi.
No.
I see Jacobad Institute of Medical Sciences. They have a group of around like 30 clinicians and physicians sitting there. Do they have any question? Dr. Tugger from Jacobad, do you have any question? I see a caller number 2. Don't see the name. Does caller number 2 has any question?
Dr. Somro, I think Dr. Rizwan has some question. We are trying to unmute him. Give us 1 minute.
Okay.
Dr. Naeem, we don't see your name in the list.
I think Dr. Khatri is back online, so he probably is available. Dr. Sumra?
Dr. Khatri, I see you online. Do you have any question? Dr. Khatri, please. Okay. Jacobad Institute of Medical Sciences, they're trying to reach out to us for questions, and I don't know how to help them. Dr. Fiza, do you have any idea?
No, actually, we don't see them. We have.
Is Wasim,
Okay.
his name is Wasim. I see them online.
Just a minute. First, we'll do this color 2. I think this is.
Dr. Rizwan. Caller 2 is Dr. Rizwan. Caller 2 is Dr. Rizwan. Go ahead, Dr. Rizwan.
We unmuted everyone. So color 2, Dr. Rizwan.
Okay, so I will go back to the Jacobad Institute of Medical Sciences. Do they have any question?
Let's take Dr. Wasim's question first.
Okay. Dr.
Dr. Wasim, our screen is saying you are self-muted. Can you please unmute your computer, your speaker?
Jacobad Institute of Medical Sciences, go ahead. Let me get them on here. Go ahead, ask the question. Can you hear them from here, Dr. Fiza? Go ahead and ask the question. Jacobad, go ahead.
Any questions?
Go ahead, ask the question. Jacobad, go ahead. Okay. Okay. Dr. Fiza, do you want to make any closing comments today?
Yeah, sure. Just a minute. Yeah, give me 1 minute.
I see
Okay,
Dr.
so
Khatri back. Can we try Dr. Khatri? Dr. Khatri, go ahead. Do you have any question? I see Dr. Rizwan also online. Do you have any question?
yeah, I'm telling them if you cannot unmute yourself, then please type your question in the queue so we can read it and we can tell everyone.
Okay. Is there any question in the queue?
Let me check. No, I don't think so. Okay, so let's go ahead and do our completion.
Okay, go ahead.
Thank you very much, everyone, for attending and for listening to this. So after discussing this, we all know we need to put more resources into our systems. And so I think we all should work together. And these are some slides which we have been presenting from our webinar 1. I will just move quickly from there. We just discuss how we do the provider empowerment. I think this is the first step of doing the provider empowerment, that we provide the knowledge of different resources, how we manage the HIV disease here in USA, and what can be done and what should be our thought process for Pakistan. Then provider patient communications, we discussed that in past a few times. I'm just going forward with this. And we also discuss the standard precautions in our webinars. We discuss the myths and facts about HIV stigma and HIV disease. We also discuss a long list of possible HIV transmission modes, and those were based on different research studies coming out of Pakistan. So far, we were able to collect like 64 research studies from different villages, different small towns, but they all had HIV positive cases. So this was our last webinar. And what's next? We will keep you posted about our next steps, and we are focusing more on providing CME educations, providing telehealth to our providers, and it all depends what is needed and what you can ask for. Our groups are ready to provide any kind of online consultancy or online education to different providers, different groups, medical students. And my focus will be more on providing CMEs to providers and developing some modules for medical students in colleges and giving them some tools to go in the communities and talk about this disease. So we really acknowledge our institutions which gave us time to work on this project, 6 webinars in 6 weeks. was a lot of work, but our team did a good job. And we have Providence Boston Center for AIDS Research. They allowed me to work on all of this, collecting the groups, collecting the guest speakers from everywhere. And I'm also affiliated with Brown University Medical School. Then we are also thankful to Jinnah Sindh Medical University for encouraging us and working with us, and Jinnah Sindh Medical University Alumni Association of North America, Dr. Somru and Dr. Rizwan Naeem and Dr. Suleiman, they are all members of that, and we are very thankful to them. And also Apna Institute of Public Health, and they provided us the moral support. And our team members, and I think then we are all done. We have a long list of references. So let us know, and you can contact us. You have our emails, so send us your questions and contact us whenever you need us. But we will be moving forward with our next aims, creating some CMEs and starting some telemed programs. Thank you very much. And Jamie, any other comments you want to summarize?
No, other than thank you for letting me participate, and if I can be of any help at all, let me know, and I wish you all well.
Sure, thank you very much.
Thank you for your help, Jamie.
Thank you.
And Dr. Rizwan, do you have any comments? I think we are having some technical problems today. Yeah, they cannot either hear us or they cannot participate, but I don't know. I'm sorry, and I apologize for that. So Dr. Rizwan Naeem, you can send us comments after, and you are a very active part of our team. So we'll be hearing from you very often. And thank you very much, everyone who joined today. And Khuda Hafiz.